Class. This is my case study response for a CVA or a cerebral vascular accident. I just want to preface this by saying that this particular case study actually took place in real life, and it was my father. So the patient was a 45-year-old male presenting to the emergency department via ambulance after his wife had called 911 from home. Richard was not feeling well at home earlier in the day and had a complaint of a headache. His wife called 911 around 2 a.m. when Richard got out of bed to go to the bathroom and complained of nausea. Richard fell to the floor in the bathroom, had difficulty speaking, slurred words, and was unable to stand. Richard's past medical history included kidney stones, daily alcohol use, and an occupational exposure to chemicals used in dry cleaning. On physical exam, the patient could not perform any serial addition, had slurred speech with tongue deviation and left-sided weakness. Blood pressure was 186 over 102, heart rate of 90, respiration rate was 18, shallow, and the patient was afebrile. Richard's wife reports that the patient has not seen a doctor in several years other than when he was hospitalized for kidney stones and a lithotripsy. So you suspect a stroke with these symptoms and activate the stroke protocol in the emergency department. The finger stick blood sugar was 98, an IV line was placed, and the subsequent labs of a CBC, BMP, MAG and FOS, cardiac enzymes are all sent. CAT scan is notified and the patient is brought directly to the CAT scanner. Findings on the CAT scan indicate a right temporal bleed with a midline shift. It's pretty significant in size there. While in the CAT scan, the patient's condition worsened and he was unable to protect his airway. So Richard was brought back to the emergency room, intubated and sedated, and admitted to the ICU for further care. Unfortunately, there's no available intervention or treatment for this hemorrhagic stroke, the place and the depth that it was in the brain tissues. So Richard went on to have multiple seizures, which are known to increase the risk of damage to the brain tissues. Glasgow Coma Scale of less than 8 at presentation, but the larger the hemorrhagic volume and the larger the interventricular hemorrhagic volume has been identified as predecessors for post-stroke epilepsy and patients with intracranial hemorrhage associated acute symptomatic seizures. And there are my references. Thanks.